Good afternoon. You have listened to the importance of pre-PCI OCT, but post-PCI OCT is equally important or sometimes more important for clinical outcome. When you look at the algorithm for the OCT-guided precision PCI, all the three factors are equally important. The pre-intervention assessment, the optimum stent deployment, and the post-stent assessment. In the post-stent assessment, we mainly look at three important areas that comes in the MLD max. The MLD is actually the pre-PCI, in which you have the morphology, the lesion length, and the diameter. And in the post-PCI, we have the max, that is the medial dissection, the apposition, and the expansion. We have to address the significant dissection. We have to address the gross malapposition and correct the under-expansion if it is present. It is certainly likely to improve the clinical outcome. The edge dissections are extremely common and is seen in OCT in up to 60% cases of PCI. But we know that 80% of these are not picked up by the coronary angiogram and may not be having clinical significance. But we should remember that major dissections do predict adverse outcome. In the CLI OPCI registry, linear rim of dissection tissue with width more than 200 microns was associated with 2.5-fold higher MACE with distal dissection. But proximal dissections, if limited, are many times benign and often do not lead to MACE. So overall, we can say that distal dissections are more important than the proximal dissection. And when you find a dissection like that, have a look at the extent of dissection. How much is the arc? Is it more than 90 degree, extending beyond one quadrant or less than one quadrant? If it is just an intimal tear, less than 60 degree or 90 degree, confined to one quadrant, probably it can be ignored, especially if it's a proximal dissection. But something more than one quadrant, more than 90 degree, with intimal tear or a medial tear or intramural hematoma certainly require correction. So the dissection penetrating the medial layer and is greater than one quadrant requires an overlapping stent. Now, stent malapposition. We should clearly differentiate between malapposition and under-expansion. Both can coexist. When you tell about malapposition, lack of full contact between the stent studs and the vessel wall. Acute stent malapposition is observed commonly. If you use an OCT, minor degree of malapposition is very common. Potential impact on stent failure, stent thrombosis and in-stent restenosis. Acute stent malapposition without under-expansion has not been seen to be associated with MACE in the IVA studies. It's a little controversial whether it's important or not. Proximal edge malapposition that may interfere with the rewiring because it can go abluminal. Gross malapposition of long segments or malapposition associated with under-expansion need correction with a semi-compliant balloon. And that is what is shown, longer than 3 millimeter and exceeding 300 microns. They require dilatation with a semi-compliant balloon. And we have the rapid visualization of the stent apposition with the E4 software, so that the color, the white dot indicates a well-apposed stent, whereas a red dot indicates a mal-apposed stent, as is clearly seen. Then the stent expansion, measured in relation to the reference vessel, more than 80% will be acceptable, but more than 90% is the optimal one. If it is not achieved, post-dilate with a non-compliant balloon at high pressures. And how to measure the reference vessel area? It's very important. The ideal thing will be at this site where you have the MSA measured, you require the vessel reference diameter. The EEL to EEL will be the ideal thing. But conventional stent expansion, you go by the average proximal and the average distal reference lumen area. But it has limitations. And the stent expansion, you look at the diameter as well as the area. If the distal area stenosis is more than 10%, it certainly requires correction with an non-compliant balloon. And proximally again, look at the proximal box. If the stent, here you find it is the stent area, it is 13.7%, that requires a correction. Let me show 3 cases. This is a case of post-RCA stent implanted 2 years ago, recent onset effort angina. Obviously, it's a case of instant restenosis. Pre-OCT, pre-PCI OCT will clearly tell about the mechanism of restenosis. And after preparing the bed properly, it was stented with a 3x48 drug-eluting stent, then post-dilated. But ultimately, you find there is some haziness in the distal part. And what exactly is the reason for that? If you want to figure it out, you require an imaging. It could be a pre-existing lesion, it could be a plaque shift, it could be a protrusion, or it could be a dissection. Now, that has been clearly answered by an OCT. When you look at the OCT, you find there is a clear-cut dissection. You can see it now, that is involving the media and extending into almost 180 degrees. So this certainly has to be corrected. There's no doubt about that. And an overlapping stent is certainly required. This clearly shows that dissection flap, and if it is left like that, it will be very dangerous. Moreover, it's a distal dissection as well. And it was covered with a 2.75 into 23 stent and comfortable. Yet another case, this is LMCA, trifurcating into LAD, ramus, and left circumflex, tight LAD ostial lesion. And this is the pre-PCI OCT showing that the ostia are patent. The ostia of the ramus as well as the circ are patent. So a single stent strategy will be enough. Provisional stenting, so 3 into 33, stented from the LM to LAD, post-dilated with a 4 millimeter optimization for the LM, and that shows the good apposition. That white color indicates the apposition is very good. It is less than 200 microns. There is no red flag anywhere. And the minimal luminal area as well as the stent expansion, everything has been shown. The central part requires some post-dilatation. And that is again shown there. The reference diameter is also shown. And when you look at the ostium looks okay. So there's no need to address that separately. And the bifurcation PCI, this has been discussed in great detail today. The side branch assessment with OCT, very important in a post-PCI situation. The apposition indicator is shown there in that rendered stent. We can clearly show whether there are any studs across that circ ostium. Here it is actually a circ to the OM. That OM ostium is very clearly shown. And here, the distal stud as well as the proximal studs are there across that ostium. And this was discussed in detail by Dr. Ankush Gupta today as to what should be done for that. And the studs, excess of studs projecting can later get endothelialized and can compromise the blood flow, and they can come back with restenosis. That's an important issue when you do this stenting from LM to LAD. The circ ostium is the usual one which creates problem. The third case, again the same thing. LM looks fairly normal. The circ looks normal. The ostium looks normal. So naturally it will be a single stent strategy from the LM into the LAD. After preparing the vessel well, stented with a 3x38 drug-eluting stent, post-dilated, and optimized proximally. And this is what is shown. This is the important point with Dr. Ankush Gupta discussed today. There are a lot of studs across the circ ostium. And also you find the stent is not totally expanded and not properly apposed. So here you have malapposition as well as under expansion. When you have a combination of both, it is an indicator of stent thrombosis as well as ISR. But if you have just malapposition, but no under expansion, and if the MSA is good, then you know the restenosis will be comparatively less. Here the area is shown there. The proximal is 6.56 reference. The distal is 5.34 and the MSA is 4.69. And so, you know, it's not very optimum. It can be optimized further. And here you have the combination of both malapposition as well as under expansion. And that is showing the ostium very clearly. And subsequently that has been corrected. You can see the balloon across the circ ostium. And after that you find the studs have been completely eliminated from the circ ostium. So naturally you can expect for a long-term better outcome. So that's the important point, which it becomes all the more important in a two-stent strategy, as has been discussed today in the DK crush, and it was pointed out already the DK crush has a lot of, you know, a lot of steps, and if you start doing it in a very perfect manner, it requires a lot of hardware, a lot of time, a lot of contrast, but okay, there is some suggestion that it may yield to a better outcome. And the other important point is sometimes you find plaque or thrombus protrusion. If it is exceeding 200 microns and the edge and protrusion area by stent area, if it is exceeding 10%, it requires correction. So let me conclude the post-PCI optimization targets. These are all the important targets. The optimal stent expansion, avoiding of landing zone plaque burden, more than 50%, or a lipid-rich tissue, avoidance of large malapposition. If there's minimal malapposition, there's no underexpansion. If the MSA is more than 4.5, maybe you can ignore. Avoidance of significant irregular tissue protrusion and avoidance of significant edge dissection. Thank you very much, and I would like to thank Dr. Jabir very specifically for providing me this video, and Dr. Oni for this kind invitation. Thank you very much.